So next, I will be kind of pivoting and discussing the other portion of acute stroke, which is intracranial hemorrhage. And I'll really be focusing on some guideline updates as well as talking about the concept and importance of a code ICH. I do not have any disclosures to report on this topic. And in terms of objectives, we'll briefly go through the background in epidemiology. I tried to include some data that's specific to Latin America, the Dominican Republic. We'll talk about the importance of hematoma expansion and anticoagulation reversal. There were new American Heart Association guidelines in 2022, which we will touch upon. I'll try and cover a little bit the future of ICH care, which includes minimally invasive surgery, and there's some cases at the end. So in terms of intracranial hemorrhage, intracranial hemorrhage can refer to several different compartments in the brain, whether it's a subdural hematoma, an epidural hematoma, subarachnoid hemorrhage, or parenchymal hemorrhage. Some people will also call parenchymal hemorrhage IPH, intraparenchymal hemorrhage. So throughout this talk, we'll be focusing on the parenchymal hemorrhage component. And when we think about strokes as a whole, only about 10 to 15% of strokes are going to be hemorrhages, where the remaining portion are ischemic stroke. However, they may be accountable for less strokes, but these patients do not do as well. It's more common in people that are from lower resource populations, and they don't do as well. There's a very high mortality that's been reported as high as 30 to 40% within the first 30 days. And I think one significant thing to think about is, we just heard from Dr. Shepard that over the past 20 or so years, we've had significant advances in the care of our patients with acute ischemic stroke. We've had thrombolytic therapy, we've had thrombectomies, we've had advanced imaging techniques, use of artificial intelligence to help identify which patients we should select for these procedures. But in intracranial hemorrhage, we haven't had those same advances, and patients are not doing any better or any significantly better. The other thing to consider in terms of the future and seeing more of these patients is that patients, while anticoagulated, have a higher morbidity and mortality. So when you have someone on anticoagulation, they have a higher risk of hematoma expansion. You'll see that abbreviated as HE, which then will cause neurologic deterioration and a worse outcome. That's 3 to 6 times higher of developing hematoma expansion when patients are anticoagulated. As our population ages, there will be more patients that are on these anticoagulants for things like atrial fibrillation, thromboembolic events. And while we have better anticoagulant agents like the anti-10A inhibitors, they have lower risk of hemorrhage when compared to things like warfarin, that still is not a zero risk. There is some risk when we treat patients with these medications. So in terms of ethnic disparities in stroke, there's a lot in the literature about how black patients have higher risk in terms of incidence when compared to white patients. And I was curious to see what I could find in terms of Hispanic patients. There's not as much, but I thought this was a nice summary in terms of overall incidence of all stroke, not just intracranial hemorrhage. And essentially what they found is they broke it down into white, black, and Hispanic, and blacks have the highest incidence rate, followed by Hispanic, and then whites. And when they looked at different things that might be contributing to that, what they found is that in these groups, if they were less educated or did not have good insurance, and by when I say not have good insurance, they were saying that that is a surrogate marker for a lower socioeconomic status. They had a higher risk. And one other factor I thought was interesting was when they looked at specific by age and gender, women over 70 years old in the Hispanic group had a significantly higher incidence when compared to these other patient groups. And when we think about strokes, it's not just how often it happens, but what happens afterwards. We heard about the importance of post-stroke care. So this was a paper that looked at disparities in post-stroke care, and this specifically focused within Latin America. It's a little biased because they were going by the diagnosis of stroke as being self-reported. But what this box here on the top shows is within the Dominican Republic, they had about 169 respondents, and a third of those patients had severe disability. And then when they looked at who takes care of these patients, this box is showing that about a quarter are taken care of by their spouse or significant other, and about half are by their children. And what's really interesting is they found the same pattern as that prior study where the older you are, the more likely you are to have a severe stroke, which is not surprising. But similarly, they found lower education was a higher risk of having these severe strokes. Another, I think, pretty intuitive finding was that those with dementia or depression are more likely to have higher or more severe disability. So moving forward, we'll be kind of touching upon some of the 2022 guidelines. These were published by the American Heart Association. In addition to that, I'll show you some more recent evidence and evidence that should be coming out this year where we have preliminary data on things that might change the practice of intracranial hemorrhage for patients. So we've kind of been reviewing this in some of the other talks, but just as a reminder, there's two different ways we can think about quality of evidence. You'll see things listed as class of recommendation, or COR, and that's just really class 1 is very strong, and then the higher the number, the weaker the recommendation. And then you have level of evidence. I might abbreviate it as LOE throughout the slides. And basically, the best kind of evidence is level A, meaning you have randomized control trial, where it's very high level quality evidence. You control for almost every factor. You can really specify what the variable is that you are looking at. And then you get lower quality of evidence as you go down to B, C, where really you're going down to things like meta-analysis, case reports, or cohort series, where the level of evidence is not as good. Now, in terms of imaging, this is, I'm sure, something everyone knows, and we've already talked about. When you see someone with stroke-like symptoms, you cannot tell whether it's an ischemic stroke or hemorrhagic stroke until you get your non-contrast head CT. So that's the most basic recommendation in terms of imaging. I think what's also pretty standard practice is to get a follow-up scan to assess for stability. There might be variation in practice as to when you get that follow-up scan. At most institutions I've been at, we typically get our initial scan. If we identify an intracranial hemorrhage, then we'll be getting a repeat scan in about 4 to 6 hours. If that's stable, I don't necessarily get any further head CTs unless there's a neurologic change or procedures happened, because they'll likely eventually get an MRI as well within the next day or two. If on the follow-up scan there's been hematoma expansion and that hemorrhage is larger, I will repeat another head CT in another 4 to 6 hours, because depending on where that hemorrhage is, they might end up needing a neurosurgical intervention or even management of elevated intracranial pressure. So this is just an example showing hematoma expansion. In terms of intracranial hemorrhage, there's very few things we can do to try and improve outcomes once it happens. And minimizing the risk of hematoma expansion is one of the things that's potentially modifiable. And we know that people that develop hematoma expansion have worse outcomes. And we know that blood pressure control is one thing that we can do to work on it. So in terms of blood pressure control, you want to be as quick as initiating it as possible, but you don't want to be too aggressive, because if you drop it too quickly, you risk hypoperfusing the brain. So this has been an area of controversy in terms of how aggressive you should be with blood pressure control, and we'll touch upon that in a few slides. As I mentioned, anticoagulant use increases the risk of hematoma expansion, and so it's something else to keep in your mind, and why it's so important to assess if the patient needs anticoagulant reversal. So these pictures are just showing, picture A is showing your hemorrhage. On the left, where the arrow is pointing, there's a hyperdensity within the hematoma, and that's actually the spot sign. So this tells me that the patient's at risk for having hematoma expansion. So that spot that you're seeing here is actually extravasation from the blood vessel into the hematoma. And when they repeat the CT on post-bleed day 1, which is 24 hours after this one, you can see that, in fact, that hematoma has expanded. These are a couple other radiographic signs that can be helpful in terms of differentiating patients at risk for hematoma expansion. So the one on the left is just showing some hyperdensities in the hematoma, and then the one on the right is the swirl sign. Essentially, if you see any kind of abnormal layering or hypodensities within the hyperdensity that is the hemorrhage, you might be concerned that there's risk for hematoma expansion. So hematoma expansion, I mentioned that it's important because it affects outcomes, but I don't think people recognize how strong that relationship is. So what we know is that hematoma expansion is an independent predictor of poor outcome, and that's even when we consider the severity or the baseline volume of that intracranial hemorrhage. We know that 1 milliliter of hematoma expansion actually leads to a 5% increase of odds of death or dependence. And the reality is, when these hematomas expand, it's never 1 ml, right? It's 5, 10, even more. So it's a significant increase in having a worse outcome. And when these hematomas expand, you also risk the development of intraventricular hemorrhage, or IVH, which also is another predictor of poor outcome. So when we're thinking about outcomes, we do have a couple scales that we can think about in terms of stratifying good versus bad outcome. So the ICH score, which is one of the older scores, which predicts a 30-day mortality. The higher the score, the worse the outcome. And essentially, every risk factor that is an independent risk factor for poor outcome gets you a point. So whether it's age, being over 80, the location, if it's infraventricular, the volume being over 30 mLs, the presence of intraventricular hemorrhage, or having a lower GCS. So we got a question about the GCS earlier. I think this is one application where I do use it in my practice for intracranial patients because for part of our documentation purposes as a comprehensive stroke center, all of these patients on admission need to have an ICH documented, and it's sometimes helpful in communicating with family. That being said, there's a lot of criticism of the ICH score that when it was developed, there was a self-fulfilling prophecy. We talked earlier this morning about withdrawal of life-sustaining therapy, being that was the most common cause of death after cardiac arrest. But I think in prior years, that was also a pattern noted in these patients with large intracranial hemorrhages. We see maybe an older patient with a large hemorrhage, and we tell the family it's not good. I don't think there's a meaningful chance of meaningful outcome, but we now know that's not always the case. So I'm a little more cautious in using this outcome scale. The FUNC scale is another one you can use, and instead of mortality, this one predicts functional independence at 90 days. It uses similar factors, but risk stratifies a little more sophisticated in that you will break it down to age into different tiers, volumes as well, and takes into factor whether there is pre-ICH cognitive impairment. So we talked about hematoma expansion being a really powerful predictor of poor outcome, but I wanted to show you that in terms of pictures. So we have a CAT scan here that's showing, a pretty large subcortical intracranial hemorrhage. Now, if we think about calculating the ICH score for this patient, who wants to tell me what that is? I'll say it's an 80-year-old woman. She comes in with hemiparesis. Her GCS is 13. The ICH volume is 25. So what do we think this ICH score is? It doesn't meet the volume cutoff, correct? It's under 30. Do we see intraventricular hemorrhage? No. Is it infratentorial? No. Her GCS is 13, so she doesn't get a point for that. So she gets 1 for age, correct? She's 80 years old. So based off of an ICH score of 1, that's a 13% chance of mortality. If we were to calculate her FUNC score, I won't go through that, it's a little more complicated, but it's a 42% chance of independence at 90 days. So it's someone that's here, being able to live alone, take care of themselves, complete their daily living activities. If she were to develop hematoma expansion and now has intraventricular hemorrhage, the volume is over 30 mLs, and her GCS is now 9, we're up to an ICH score of 4, which is a 97% chance of mortality. And if we calculate the FUNC score, it's 13% chance of being functionally independent in 90 days. So that's this scenario. Someone's living in a facility requiring care 24 hours, may or may not be on a ventilator. There's a huge difference. So I think when we think about hematoma expansion, we need to recognize its importance and do everything we can to minimize it. So one thing we can do is blood pressure reduction. So there's somewhat controversy over what is the best blood pressure goal, and there's a lot of practice variation between institutions. Based on the AHA guidelines, they basically made a recommendation based off of INTERACT and ATAC2, and they're saying that avoid blood pressure variability. We want it to be smooth, and we don't want it to be too aggressive. Avoid lowering below 130. If someone comes in at 220, or below, the goal is really going to be a range of 130 to 150. Because the important thing is, we also know that if your CPP or your cerebral perfusion pressure is too low, that's also not good. So we want to maintain our cerebral perfusion above 60 to 70. There's no clear guidance regarding what's the best medication to use for this. I'd say most places I've been, the protocols usually involve giving a 10 milligram dose of hydralazine or labetalol once or twice, and then if we're not at goal, then I want to aggressively move to either a nicardipine or clofidipine infusion, and those patients do need arterial lines, so we can very closely monitor their hemodynamic status. We mentioned the importance of hematoma expansion. Blood pressure reduction is one thing we can do. The other is really assessing need for anticoagulation reversal. So these are the recommendations from the HA guidelines, and I just highlighted a few key changes. So the prior guidelines recommended reversing to an INR of less than 1.4. The new guidelines treat to an INR of less than 1.3. And here, they've actually updated that if you have andexanet alpha available, which is to reverse an anti-10A inhibitor, you should give that preferred over a 4-factor PCC. Not all institutions have it available. It is expensive, but I'm going to show you some data as to why we should consider using it. So andexanet alpha, otherwise known as Indexa, it's basically a modified decoy protein, and what it does is it binds to that anti-10A inhibitor, which is the rivaroxaban or apixaban, and it's going to reduce its blood thinning activities within the blood. So it's going to reduce the amount of, the way I explain it to you and family members is reduce the amount of thinness in the blood so we can prevent more bleeding. It was FDA approved in 2018 for reversal of these 10A inhibitors due to life-threatening or uncontrolled bleeding. In terms of its pharmacokinetics and pharmacodynamics, it does have a very short half-life, so it's given as a bolus followed by an infusion. And when we dose it, the important things to know in the patient's history is when was the last dose that the medication was taken, and if you have the dose available. If you don't have either of those information, then there is dosing recommendation here. But if you can get that information, it's useful. And what I think is really awesome about this is that we talked about time is brain. Hematoma expansion, the majority of it actually happens very soon, within like the first 3 hours of symptom onset. So if the patient comes in, we identify there's an intracranial hemorrhage, and we can give this medication within the high risk time for developing hematoma expansion. Within 2 to 5 minutes after giving that bolus, we've almost reduced the anti-10A circulating levels to nearly 100%. So it's going to be a huge factor in minimizing our risk of hematoma expansion. So Indexa 4 is one of the first trials that actually looked at this. Most of these patients were on an anticoagulant for atrial fibrillation, and the majority of these patients had intracranial hemorrhage, but there was a significant amount of patients that had GI bleeding. And what they really looked at was the circulating level of anti-factor 10A in the blood and hematoma efficacy or hematoma expansion. And what they found was, you can see in these boxes, this is their baseline levels of anti-10A levels in the blood, and once the bolus is done and the infusion is done, it's essentially zero. It works that quickly. And then when they looked at hemostatic efficacy, you can see this is the intracranial patient group. The majority had good or excellent hemostasis. So this is really what the data that came from to drive FDA approval for giving this medication. However, due to the fact that it's expensive and it's not necessarily, we don't have good data to say it gives better functional outcomes. Many hospitals have not transitioned to it. I do have it on formulary in my hospital. So the next big trial that everyone's talking about right now is Indexa I. There's some data released at the World Stroke Organization last fall. The publication is pending, but essentially this is the first trial to actually look at a head-to-head comparison of 4-factor PCC versus andexanet. All the other data we have comparing them is retrospective, cohort, meta-analyses, so people are very excited about this. It was actually stopped early because they found that there's a significant superior hemostatic efficacy when they compared it to usual care, which was PCC. In terms of the results, there are about 260 patients in each group. I would consider relatively small hematoma volume, about 10 cc's. And when they looked at hemostatic efficacy, the andexanet group was 64%, whereas usual care was 52%. However, they did not find any difference in functional outcomes at 30 days or any difference in 30-day mortality. And the hot topic that people are very most interested in seeing this publication for is that there is an increased risk in thrombotic events in patients that received andexanet. People are saying, you know, their guess is that the patients that had the higher thrombotic risks already had a history of something previously thromboembolic, whether it was an MI or prior ischemic stroke. But this is a very hotly debated topic, and I know a lot of people are reading this publication. So in terms of the future of anticoagulation reversal, people are waiting for the ANEXA-I study to come out. ANEXA-RS, if you look it up on clinicaltrials.gov, it was listed as starting in October. However, I was just speaking with someone from the Scientific Council for Indexa, and they said they're still actually enrolling sites and have not started the trial yet. But all those prior studies excluded patients that had neurosurgical indications, whether it was an EVD or a decompression. So this will be a study to actually look at patients that need some kind of neurosurgical intervention and see if there's any difference in terms of whether they get a PCC versus Indexa. Ultimately, though, these studies really only follow patients for up to 30 days, so we might not be seeing a difference in functional outcome or mortality because we're not following them for long enough. We know that based off of our clinical experience, a lot of patients with intracranial hemorrhage don't get significantly better until 3 months, 6 months, a year out. So I think there's more to come in terms of what we'll see in the future of research in this area. I won't speak too much on this because this is what a lot of us do in our common practice, but the guidelines do discuss which further imaging is necessary. So essentially, anyone under 70, they do suggest getting a CT angiogram to rule out like an AVM, a vascular abnormality. That's my practice that we typically do for most patients. If they have CKD or something where I'm concerned about their underlying renal function, then I might hold off and just get an MRA because I'll likely be getting an MRI in the future. If they're young, don't have an overt etiology, and the MRI is unrevealing, I usually push for those patients to get a DSA or an angiogram because that's something you don't want to miss. If it's also particularly ventricular predominant, if you have mainly IVH and only a small component of parenchymal hemorrhage, those patients are at higher risk for having some kind of periventricular AVM or fistula and really should consider getting an angiogram. For inpatient care, we actually have data to say that patients with moderate to severe intracranial hemorrhage do better when they are cared for by patients in an ICU. That's because we have nurses that are trained to monitor for changes in their exam. People like Dr. Shepard and I, who this is all we do is neurocritical care, and we know that there's a reduction in mortality, length of stay, need for mechanical ventilation, and improved outcomes. We work with our neurosurgical colleagues because, as I'll show you, there are certain patient populations where there's evidence to say they should get a surgical intervention, specifically those with intraventricular hemorrhage or a posterior fossa lesion. And like we talked about for the ischemic stroke patients, standardized order sets are critical to maintain that we are following the guidelines and reduce complication rates. About 30% of these patients can have cardiac complications, so the guidelines do recommend that these patients get, at minimum, an EKG on admission, a troponin level, and are on telemetry or cardiac monitoring. And like any patient that gets admitted to the ICU, they're at risk for developing infectious complications or other ICU complications that develop when you're in the hospital for a long time. Briefly, just to talk about surgical treatments. So for patients with the supratentorial ICH with IVH, we know that an EVD is going to help them. So EVD is considered standard of care for patients with intraventricular hemorrhage and hydrocephalus, and that's a very strong recommendation. Another recommendation that we know will improve outcomes is for patients with a cerebellar hemorrhage, and they specify over 15 mLs in volume, and especially if they're deteriorating, have brainstem compression or hydrocephalus, those patients should be evacuated for a suboccipital craniectomy where they take the piece of the bone off in the back, allow the swelling to go out instead of pressing in on the brainstem. And these people can actually do really well. They can come in comatose with a very bad exam, go directly to the OR, and the next day you can extubate them, they're awake, they're talking to you with very minimal neurologic deficits. I think the future of managing these patients is really going to be to get more data on minimally invasive surgery because when we think about it, the whole thought process is we can reduce the hematoma volume, and when we reduce the volume, we'll be able to reduce perihematomal edema and therefore minimize the amount of injury that happens to the normal brain tissue around it. So right now, the largest RCT that we have is MISTI-3, and basically they showed that there's lower mortality in this minimally invasive surgery group, but no difference in functional outcome. So there's ongoing trials right now that are looking at different endoscopic or stereotactic aspiration, and sometimes they actually use thrombolytics to break up the clot to be able to kind of suction it out better. And we know that's safe and might be able to be used to reduce mortality. However, the current evidence we have was not strong enough when these guidelines were released to include that in them as a strong recommendation. This is another trial that I think people should keep an eye out for that was briefly discussed at the European Stroke Organization meeting in 2023. So this is the ENRICH trial, and this is the big trial that people are excited about for minimally invasive surgery in these patients with intracranial hemorrhage. So basically, these patients, they looked at deep and lobar hemorrhages and had this actually is a device that they used to go in and kind of suction out the blood. And the primary outcome is functional outcomes at 180 days. So I think keep an eye out for that. I know someone who works for that company, and she said that the data should be released very soon. So I think that's another thing that might revolutionize the care for these patients. Things that we know don't work. Prophylactic corticosteroids. We don't do that in these patients. It's not going to help. Same thing for hyperosmolar therapy. The only time I use hyperosmolar therapy in these patients is if they have radiographic herniation and they're clinically symptomatic. I don't just treat the picture, I treat the picture in combination with the patient. So we don't do prophylactic hypertonic or prophylactic mannitol. I'm going to treat based on the patient's exam in combination with what I've seen on their imaging. We know that platelet transfusion should not be used if they are not going to need a neurosurgical procedure. So any patient that has been on aspirin or Plavix, if they don't need an EVD and they don't need a decompression, we do not transfuse platelets. We have very good evidence from the patch trial that these patients actually do worse when they get transfused. It's thought that there's an inflammatory reaction with the blood transfusion that led to poor outcomes. There's ongoing data and not enough to really comment on the use of DDAVP, but I think that's another area of interest that we might hear more about in the future. Compression stockings are not effective for DVT prophylaxis. I know a lot of the surgeons I work with sometimes get nervous to do prophylactic dosing heparin or Lovenox after someone's had an intracranial hemorrhage. We have evidence that it's safe and actually necessary to reduce complications. So from 24 hours from my stability scan, that's when I start my DVT prophylaxis in patients. We also know that prophylactic use of anti-seizure medications does not improve long-term seizure control or functional outcome. There was a recent trial, the PEACH trial, which looked at this because the problem with this data is a lot of the older studies used medications like phenytoin, which when in itself has side effects. Now there's newer studies that are looking at the use of Keppra, which is what a lot of us tend to gravitate more towards using. And I think this may or may not change in the future depending on more data, but at the moment there's no evidence to support giving prophylactic anti-seizure medication in someone with a hemorrhage unless you have electrographic evidence of seizures. What happens outside of the hospital matters. So Dr. Shepard alluded to this, and basically early symptom recognition is crucial. So with ischemic stroke, we know the earlier we identify them, they're in the window for thrombolytic therapy, that's great. I think we forget that for intracranial hemorrhage patients, people think there's nothing to do, but there is something to do. We can work on their blood pressure. If they're anticoagulated, we can reverse that. So I think we need to work on public awareness, educating for stroke recognition, as well as transportation and triage. From what I've heard, that can be challenging here. But we do a lot of education with our EMS system in terms of stroke recognition, how to triage to which hospital is the closest and can provide the care that that patient needs. And pre-hospital notification, there's data to show that when the hospital is notified by EMS in advance that the patient's coming and there's concern for a stroke, they actually get their imaging done faster and can have better outcomes. So this brings us to the concept of code ICH. We saw lots of nice flow charts from Dr. Shepard about everything is timing, what we need to do for acute ischemic stroke patients. And then there's a box that said ICH. But that box should then have its own separate flow sheet for things that we need to do, and there should be time-locked goals for how to achieve that. So we basically need a more rapid and standardized approach for how we approach these patients. So what some of the leaders in our field are proposing is something called a code ICH, where once you've identified that the patient does have a hemorrhage, you're working on aggressive blood pressure goal with a target of 130 to 150. You have an order set. We talked about the importance of order sets so you don't miss anything. And then you're going to get your vessel imaging if you're concerned there's a vascular abnormality, and or if they're a candidate for surgical intervention. So in conclusion, I think there's work to be done in terms of raising public awareness, transportation and triage matters, and time is brain. Whether it's an acute ischemic stroke or a hemorrhage, we really need to focus on protocolizing this care. Blood pressure is important, but we want to minimize variability and avoid hypoperfusion, and rapid reversal matters. If you have a history of the patient being on the medication, you don't necessarily need to wait for that lab value to return. You want to treat them. You want to evaluate for surgical candidacy and avoid early DNR orders, because there's actually a study published last year in JAMA that looked at these patients with intracranial hemorrhage, which have, were thought to have bad outcomes, and a year or two later, they're actually doing okay or even good. So I think we really need to rethink how we assess these patients. Do I have time for a couple of cases? Okay. I know we're probably behind. So the couple cases, case one, this is a 40-year-old man. He presented with drowsiness and lower extremity weakness, and his blood pressure is 180. You got the head CT, and this is what it shows. So who wants to comment as to how we would read or interpret this CT? Not Dr. Shepard. Someone want to raise their hand? This is the tricky one. I heard aneurysm, so yes. So basically what I want people to recognize is that you can be fooled, because if you're looking at this, you might say, okay, there's bifrontal hematoma, more so on the left than the right, and if you're really looking closely, you'll see some very thin subarachnoid blood. But I've gotten calls from other hospitals for people with this imaging where they say, I have an intracranial hemorrhage patient, and they say it's a frontal hemorrhage. And then I see the image and I say, this is a subarachnoid hemorrhage. This is likely aneurysmal. So this is one of the classic patterns you can see with a ruptured anterior communicating artery aneurysm. It's called the flame sign, where you can get frontal predominant intracranial hemorrhage. And that's important because our pathway for treating aneurysmal subarachnoid hemorrhage is different from an intracranial hemorrhage. We tend to be a little bit more aggressive about blood pressure control because the goal is you want to minimize the risk of re-rupture prior to that aneurysm being treated. So the guidelines say under 160 or a map of under 110. At most places I've worked, our neurosurgery preference is under 140. And then they're at high risk developing hydrocephalus. You obviously want to correct coagulopathies. And this is just showing, this is a lateral view showing this ACOM aneurysm right here. So, you don't want to be fooled. Case two, this is a 65-year-old man presented with right-sided weakness. He's altered. Blood pressure is 200, the platelets are 220, and INR is 2. So I guess who wants to talk about what's on the head CT first? Okay, I heard diaphthalamic, so we have so is intracranial hemorrhage, what else are we seeing? Intraventricular, what else? Hydrocephalus. So we've identified all those things. What's your first step? And people that heard this case yesterday, you cannot respond. Let's let someone else. What's that? INR? So that's one thing you're going to address. So you're going to address the INR before the INR even, your first step. So airways, breathing, circulation, ABC, any neuroemergency first. This person, this is a patient I actually had in the ICU last week. He ended up getting intubated in the ICU because he was altered, he was vomiting, he was aspirating. So you need to protect the airway, right? Because if they become hypoxic, they can have a cardiac arrest, and we want to try and minimize complications. So you've addressed the airway. I heard INR, so yes, we'll reverse that. What are your options in terms of reversing the INR? I'll tell you that the person was on apixaban. There's a few options, a couple. Apixaban, an anti-10A inhibitor. Andexanet is one. If your hospital doesn't have it on formulary, what's the other option? Yeah, so we will be doing that. So PCCs, there's still an approved four-factor PCCs. That's if you don't have Andexanet on formulary, four-factor PCCs. What else are we going to do? There's a couple other things that are important. Is this what we want? So blood pressure control, right? And what's our goal? Yeah, 130 to 150. And then one other thing we need to do, or ask someone else to do in my situation. we talked about hydrocephalus, right? So the features of hydrocephalus, the lateral ventricles are kind of ballooned, the third ventricle is large, and you can see dilation of the temporal horns. So this patient needed an EVD. I'd say it's early hydrocephalus, so if the patient had been awake and had a good exam, I would have monitored, but given the fact he was altered enough to be intubated, I asked the neurosurgery team to put an external ventricular drain in. So then this was the CTA, and there's an arrow here pointing to something. Does someone know what that is? Spot sign. So that's what we talked about being a predictor of hematoma expansion. This right here, you can see this is after the EVD went in. That's the catheter here. And then this CT was done, I think, on post-bleed day 5 or 6, and you can see that the ventricles have, markedly came down in size, and that's with diversion or draining of the CSF in the blood. His CSF was draining okay, but in some of these patients, you might have to instill a thrombolytic like alteplase to actually drain the intraventricular hemorrhage more aggressively, because the catheter can clot off and stop draining and get blocked and can become very challenging. One more quick case? Or no? Okay. So this is another patient I took care of last week, 41-year-old woman. She came in with left-sided weakness, was dysarthric. Her blood pressure is 190, platelets are 300, and iron R is 1. So this is her initial head CT. So what do we think is going on? Lower blood pressure. She was, at this point, she was awake. She was very dysarthric, so we worked on blood pressure control. There's no coagulopathy to reverse. Her platelet count is above 100. There's a little bit of trace intraventricular hemorrhage, so we kept an eye on that to monitor for hydrocephalus, which she didn't have, and we admitted her to the ICU. And the following day, I actually got a call early morning from the resident that she needed to be intubated because she was not protecting her airway. She was very drowsy, had stopped following commands. So she was intubated. And what's your first thought? What are you worried about if she's had an exam change? Expansion? What else? So did I hear rebleed? So if this was an aneurysm, yes. For her, I didn't tell you, she had a CTA, which was negative, and the pattern of blood wasn't as suspicious for something to be more of a subarachnoid. True. What other things we could explain altered mental status? Hydrocephalus, we talked about that. So I on her, but we got a head CT basically to rule out hydrocephalus, expansion of the hemorrhage, even worsening cerebral edema that can happen, especially in younger patients. Those are the big things. I mentioned she did have a CTA and a CTV, given the fact she was so young. And to me, this looked a little abnormal in its pattern of hemorrhage. And she also wasn't very hypertensive. 190 is high, but that's not usually what I see for these patients. So she's intubated, we repeated a head CT, totally stable. So what would your next step be to sort out what's going on? What else could cause altered mental status in this patient? Metabolic, sure. That's what we tell other people when they ask, but what does something a neurologist thinks about? That's what we tell the other ICUs, toxic, metabolic, check a urine analysis. What else? Seizures, right? These people are at risk for seizures. I put her on EEG, continuous monitoring for 2 days. It was slowing on the left, no seizures. So I could not figure out what's going on. So we actually repeated an MRI on her. She had already had one MRI as part of her stroke workup. And what do we see here on this? Who wants to describe what we're seeing? What's that? So this is your SWEAR area. You can see the hemorrhage here, but this is your DWI. Yeah, so she now has bilateral punctate. Well, so what's concerning about her is she had an MRI 1 to 2 days prior, which didn't have this. So this happened while in the hospital. So this is likely due to the fact that her blood pressure had dropped with intubation. Because these are in a watershed territory, right? They're kind of border zones. So we saw this, was a surprise. This still didn't really explain her exam to me. She was just so obtunded, had stopped following commands. So she actually ended up going for an angiogram yesterday because we wanted to rule out vasculitis. She's very young. She had elevated inflammatory markers. That was negative. So at the moment, we're running with the theory that this was a hypertensive hemorrhage, but she's going to need a follow-up MRI in another month or two to make sure there's nothing kind of within the hematoma bed. So thank you very much for listening. This is my dog, Jackson.